I still vividly remember 25 years ago when I was sitting in this room in the same exact situation that you're in and having mental breakdowns trying to do my platinum planner and crying in my front yard. So I totally get it. It's overwhelming. You're trying to do so much in such a short period of time, plus you're still working and you're still dealing with your families and everything. So just a day at a time, pace yourself, but stay on task. You'll get there, okay? Once you get through this semester, this is the bulk of the material. In the fall, patient assessment is this class slowed down and review. We spend more time doing a lot of the same subjects and more assessment and more hands-on stuff. So you'll see the material again, but you just have to get through the semester. And then the other class is OB/GYN, NICU, and geriatrics. So like some of it you'll know, some of it will be review. So we're going to go fast. We're going to steamroll right through, and then all of a sudden it'll be time to graduate, and you'll be like, where's the time go? It goes that fast. But I'm here if you need anything, if you need to talk. I don't want anybody to have mental breakdowns. I see that you're keeping tally. Two so far, okay.
Is that this semester, or is that?
That was today. That was just this week. After class last night, I went into my office. I clicked the tiny little button that wasn't clicked, so you could create a 220 opportunity. So that you were able to do that, and you had all the things you needed to choose. Okay, good. Mackenzie asked, I don't know if everybody was here, in your lab manuals, it tells you that if you go to clinical and you do a yellow skill, you can put a line through it and write that you went to clinical that day and did the skill, and just put which department, ER at Mid-Hudson or whatever, and you're done. You don't have to do anything more with the lab manual. You don't have to enter it a second time. You're just entering it in your clinical experience, because it's all going to clinical. That's why you have to create clinicals for the yellow skills, because when we run your clinical report, it'll show that you did it all. Okay. So at the end of the day, as long as you have all of the yellow skills, whether you did them here or you did them in the hospital or in the field, as long as they're all done, you're good. Okay? You understand? We're good? Okay. Excellent. All right, so that just leaves urology and nephrology tonight. I'm going to go as fast as humanly possible, but I really love the renin-angiotensin system. It's one of my favorites. I bet you there's an essay question next week. It really is a phenomenal system of controlling blood pressure, and the fact that we have ANH, which is the atrial natriuretic hormone that the heart releases when our blood pressure gets too high to dump the pressure. So it's a whole feedback loop, right? And if you understand anatomy and physiology and pathophysiology, it plays so well together in understanding your patient, how to treat your patient. So that is really kind of cool. But we'll do a little review. So, I mean, I'm a huge Jets fan, have been since I was, a teenager. We still haven't made it to the Super Bowl. Maybe if they get a kidney transplant.
Bernadette?
Yes, ma'am.
If I bring you a kidney, can I get out of the essay next week?
A kidney? Where are you going to come up with a kidney?
If I bring you
Has
two
it
kidneys.
I would say yes to the plot.
No, I don't want
You're just getting a shot, right?
I don't want your kidney.
I never said it would be
I
mine.
don't want a kidney from an animal. I don't like kidney. I don't like to eat kidney.
You just said you like the kidneys.
I like the kidneys, and they're really cool. Like the function of the kidney and all the stuff that little tiny organ does is kind of awesome, and you can't really live without them. So it's kind of cool. All right, so we're gonna go over some A&P. We'll talk about some disease processes and emergencies and treatments, and then we will go home. Tomorrow you have lab. You will need your gear sets. Make sure you check your gear before class. And then next week you'll need your gear sets all 3 nights. So make sure you check your gear next week every night. All right. This organ is the most anterior of the urinary system and is responsible for storing urine. What is it? Bladder. Very good. This is the duct that carries urine from the bladder to the exterior of the body. Urethra. These are responsible for transporting urine from the kidneys to the bladder. The ureters. Very good. See, you guys know anatomy? Look at that. See, a whole semester wasn't working. Tell me how male and female reproductive systems are different. What are we talking about? Okay, so females have an internal system, and they're two very separate, distinct systems. The males kind of combined, right, and it's external. If a female starts complaining of burning sensation while peeing, what's probably wrong?
UTI.
Okay, if a male complains of burning while peeing, what's probably wrong?
STD.
An STD. And men can also get benign prostatic hypertrophy, right? Because they have a prostate and we don't. So there's just different things, you know, when you're thinking about anatomy and physiology between a male and a female, you want to think about, you know, kind of what that looks like, what it means if they're complaining of pain and where the pain is, so that you can kind of differentiate. Now, I mean, a lot of times, even when we talked about abdominal emergencies, are you guys always going to know exactly what's causing the pain? Are you going to be able to, like, diagnose every single time saying, yep, that's exactly what's wrong with the patient?
Guesstimation's our friend.
Yes, guesstimation is our friend. A lot of times we just don't know, right? If they have the, you know, the whole abdomen is kind of colicky and they're not feeling good, they're nauseous, kind of hurts everywhere, maybe they're guarding a little bit. We're not going to spend hours on scene trying to figure it out. We don't have the ability to do CAT scans, X-rays, MRIs, or any of that stuff. So the best thing, and especially because a portion of those emergencies are surgical, the best part is just, you know, routine ALS, get them to the hospital. All right, so this is a very nice picture of the kidney. Where are the kidneys located? The retroperitoneal space in the flanks. Okay. The functional unit of the kidney. The nephron. Very good. How do nephrons do their job? Magic. I like it.
Hardest workers.
They work very hard, and that's why over time as we age and they start to deteriorate, kidneys start to fail. If you're dehydrated, they don't work as well. But at the same time, you can have just one kidney. All right, so nephrons reabsorb what the body needs and excrete what the body doesn't. Okay. What percent of systemic cardiac output goes through the kidneys every minute?
Oh, 25%?
25%, a quarter of our blood volume.
I don't know why I remember. Okay.
Where did you get that
information?
Hey, kudos to you.
It's the ADHD.
You know,
Is it in the textbook?
super important.
Yeah, I didn't know.
I'm pretty sure it's in the textbook. Alright, so urine is formed in the renal and medulla cortex, the renal cortex and the medulla of the, so you can see how the nephrons kind of skate between the two layers, right? You have your glomerula and then the collecting ducts go down and the loops of Henle, they kind of go through both layers. Okay. So here's a really nice picture. So the blood comes in from systemic circulation through the afferent arteriole. Now this is under a lot of pressure, okay, so this is the glomerulus, and they have slits in there, so when it's under pressure it pushes out the filtrate, right, and leaves the larger molecules still in circulation, so they don't go into the kidney. But all of the electrolytes, sodium, water, all that stuff gets to push through, okay. Then it goes through the proximal convoluted tubule, the descending loop of Henle, the ascending loop of Henle, and then the distal convoluted tubule. And then it drips the urine into the collecting duct, and then that leads out to the ureters, which then collect the urine in the bladder so that we can excrete it. Okay, so there's lots and lots and lots of these, millions of these in our kidneys, all right? But when we start talking about renal injury and damage and long-term chronic kidney failure, you start losing percentages of these over time. And when you start to get more than like 30% kidney function, start to have a problem, okay? But different parts absorb different things. So water gets reabsorbed, salts get reabsorbed, then more water gets reabsorbed in order to maintain our balance. This is where pH comes into play, because hydrogen ions, chloride ions, right, they go back and forth, making sure that we have just enough water. So if we're overhydrated, the body will excrete more water. If we're underhydrated, the body will retain more water. So The body's able to sense all of that based on blood pressure. This is why I really love this system. It's kind of really cool. Okay. Let's see, what did I say? Obviously, if there's any kind of significant blood loss, it will shut the kidneys down. So we don't want that to happen. That's why we try to maintain pressure to 90 to perfuse the kidneys. All right, so the proximal convoluted tubule reabsorbs water, sodium, potassium, chloride, bicarb, glucose, and amino acids, gets rid of the urea and the creatinine because we don't like it, and it's helping to adjust the pH because of the electrolytes. Right, the loop of Henle is where you have your osmotic gradient, allows water to pass in and out of the fluid, and again, more sodium chloride, your distal convoluted tubule secretes whatever extra stuff we don't want to maintain that blood pressure, gets rid of drugs and toxins. That's why you have to be careful. Certain patients are on drugs that are nephrotoxic. Which drugs are metabolized in the liver, which drugs are metabolized in the kidney. That's where you get the aspirin and ibuprofen. Right? Aspirin is metabolized where? Aspirin's in the liver. Because that's where if you have a overdose of aspirin, you go into liver failure. All right, so super important to make sure that it's working and able to do that. Because if it's not, then the patient's going to become toxic. And when the kidneys aren't functioning, that's where you end up with too much nitrogenous waste in circulation because it wasn't excreted properly. And like I said, urine goes out to the collecting duct. I will upload these to Brightspace one time. There's just so much going on. I don't want to like beat it a dead horse because I've already said a lot of this, but I liked the pictures and I liked that it kind of broke it down a little bit more. But this is all what I just said, right? The afferent arteriole into the capillaries in the glomerulus and going through and getting reabsorption and secretion. So those are the two functions. Reabsorb back into the blood, excrete out into the urine. All right, so functions of the kidney. I like this mnemonic. You don't have to use the mnemonic if you don't like it, but I like it. What did you say? But if it helps you remember the functions of the kidney, great. So, like I said, the kidneys are really cool. They do a lot of cool stuff. So acid-base balance is the first thing, right? So when we talk about acid-base balance, who remembers the formula for acid-base?
Can you see that?
I
Can you use a
know.
different marker, please?
Crappy markers over here. Yeah, count the others. This markers are much better. Alright, so when we talk about acid base, we have respiratory function, right? So we can blow off or retain CO2, which can shift our carbonic acid. So we have the respiratory side of it, but then the metabolic side, I really need to go home and go to bed. You people got me here way too late last night. The metabolic component is taken care of in the kidneys, right? So this is where the hydrogen ions and your bicarbonate ions help to regulate the acid-base balance by doing a lot more shifting, reabsorbing, and excreting of those ions. Water balance, right? Like I said, we get rid of too much, we retain if we're dehydrated or need to increase our blood pressure. Electrolyte balance, which we already talked about. Toxin removal, super important. We want to get rid of all the nitrogenous waste and all the excess stuff. Certain vitamins, you can take 5 million milligrams of it. If it's more than your body needs, you pee it out, except for 4. What are the 4 that are fat soluble?
K.
K.
E.
Yeah. Sure. I'm good.
I was like, I just know those.
These 4 are fat soluble if you take more than you're supposed to, you won't excrete it out of your body, and that's when you can get toxic, and potassium is the problem because obviously it throws off your cardiac function. Blood pressure, right? We're going to talk about that at length. Renin, angiotensin, aldosterone, ADH, ANH system. Hormone production, the erythropoietin makes red blood cells so that we can, right, do all the fun stuff like maybe carry oxygen. I don't know, maybe we need that. Calcium production. The only way we could make this work was detached bone. So calcium detached bone is the D. But that's for us to metabolize the calcium and the phosphorus to maintain that. Make sense?
Yes.
Helpful? Not helpful? Like I said, you don't have to use the mnemonic. If it helps you, great. If it doesn't, cool beans, whatever works for you. Alright, so this is where calcitrol comes in. I'm sure you saw this in Dave's class. Did you say who's Dave?
You have incredible hearing.
She's got the volume. No.
Last semester, I
She'll-
made so many comments. And nobody heard a word.
I'll be in that room and she'll be in the office and she'll text me and be like, watch your language.
I mean, she called out Kenzie last night.
Yeah, we're in the room.
I'm gonna scream the F-bomb.
Oh, the caterpillar.
Yes, you were screaming about the cat. I'm like, it's a caterpillar, McKenna.
It was a creepy crawl.
It was a cute little fuzzy caterpillar.
Wrong.
I kind of think if she came out with like a millipede, I might be like, all right, it was a creepy crawly, but she came out with this cute little fuzzy
No,
caterpillar.
still creepy crawly.
I would have killed her right
Still creepy crawly. Don't want it on me. Don't want
Oh,
it.
yeah.
My middle name's
All right, so the active form of vitamin D is calcitrol, which the kidneys are in charge of making, which is kind of important. So, because we need vitamin D to absorb our calcium, right, from our food and get it into our bones so that we have not brittle bones. And then we have strong, healthy bones, excuse me. All right, erythropoietin stimulates red blood cell production. And the kidney, yeah, right over there.
That was a big
I just looked over at the road.
I was like, that must be an impulse thing. I don't know the three of you over there. The body will sense if there's not enough oxygen, and it will increase red blood cell production so that it can carry more oxygen. And if there's too much, it'll decrease red cell production. So again, it's back and forth on the scale to make sure that there's enough in circulation, unless of course there's a disease process in play that it can't. Right? Some anemias, the kidney will try, but the patient's still going to be anemic because they're not going to be able to keep up. All right, so close. No urine output. Anuria. So A means none. Little urine output or decreased. That would be oliguria. Frequent urination at night. Nocturia, right? Nocturia. So night and urine. Nocturia. And then polyuria is overproduction of urine. Yeah, so in TKA when they're peeing and peeing and peeing and peeing, you don't understand why they're so thirsty. So reabsorption of electrolytes without water, formation and passage of dilute urine, which decreases the blood flow volume, is called diuresis.
Yep.
Okay. So you're going to pass dilute urine, and if you have concentrated urine, so that we preserve our blood volume, so we're excreting not a lot of water, antidiuresis. So diurese, like think about if you take a diuretic, it makes you pee, right? So when you diurese, you're getting rid of a lot of fluid, and that is going to affect your blood pressure and hopefully drop your blood pressure. So your body, again, is monitoring that pressure and is trying to get rid of it by letting you pee out more water. But if you're dehydrated, your body's going to anti-diurese, hold on to as much water as possible. Make sense? Yes. Oh, here's my favorite system. All right, so kidneys release renin into the bloodstream. The juxtaglomerular cells in the kidneys will sense when there's low blood pressure. Okay, When the blood pressure is too low, it releases renin. Angiotensinogen is just kind of floating around in our bloodstream. Renin has angiotensinogen convert to angiotensin 1. In our lungs, angiotensin converting enzyme ACE converts it to angiotensin 2. Angiotensin 2 is a vasoconstrictor. Aldosterone will help you retain water. So you have a vasoconstrictor that's going to increase pressure, retain water and salt. Aldosterone is also going to retain water. Salt always follows water, so whenever we either eat salt or retain salt, we're going to bring water. So we're going to that's going to all increase pressure. Antidiuretic hormone also gets released from the posterior pituitary. All of these things are all happening to raise blood pressure. And then, like I said, ANH. Let me see if one of my markers works. So atrial comes from the heart. So ANH is released from the heart. And it actually will sense when there's too much pressure in the blood vasculature. And when this is released, it actually causes the body to diurese and lower the blood pressure. That's how we maintain our pressure. Nobody seems to be as excited about this system.
I am.
All right, so you can draw pictures next week and explain the process, or you can write out the process, but I guarantee there is an essay on next week's test.
So if I draw it, do I have to still write?
You still have to explain it,
Okay.
like what's happening and like what's causing, what's absorbing water, what's absorbing salt, how is it increasing pressure.
Gonna do an interpretive dance instead.
You could do an interpretive dance. I would love to see that, Alex. For the whole class.
Oh no.
So he gets to dance to get out of an essay,
But you know
but
how
I
to
can't
make
bring
it.
you kidneys.
Nope.
I want to see that.
I would take some of that. Little silk.
So,
This point, I can't understand how this works about the dance. You have to keep the dance down. I'm not dancing.
you're not dancing. Can you sing though? Because you have a really pretty voice. I heard you sing before.
When did you hear her sing?
Earlier, she was singing.
Was I?
Yep.
Yeah.
Probably.
Is that after?
You were.
You were.
Yeah, that was pre or
Before, after,
post
during.
breakdown.
Pre-break job, I wouldn't know it was you because you were singing the blues, but like I already said, sometimes it's really difficult to differentiate GI from urologic because it's all in the same area. Suprapubic might be bladder. So if somebody has a full bladder, they get into a car accident, they have pain above the pubic bone, that could be, having to do with the bladder. We know, ovaries are down in the lower quadrant, so we have to worry about pregnancy and all the female issues when you have abdominal pain, but there's also intestine down there and appendix down there. So sometimes, like I said, it's not going to always be easy to differentiate exactly what's going on, but you might be able to make an educated guess based on vital signs, whether they're febrile or not, how they're walking, how they like to kind of sit, if they like to be in a ball, because they're trying to take pressure off their abdominal cavity. All right, so you can have visceral pain, somatic pain, referred pain. Visceral is going to come from an organ. Right? It's going to be kind of like colicky, not really able to figure out where it's coming from. Somatic is usually coming from muscle, so it's a little bit more easier to say that hurts out. And then we know referred pain can go anywhere from anywhere. So if somebody's complaining of severe shoulder pain, and that's the only thing they're complaining of, where should we be looking?
Gallbladder,
Possibly gallbladder. What else?
their shoulder.
Cardiac, or
They just hurt their shoulder.
they might have hurt their shoulder. Spleen, splenic injury.
You said right shoulder.
I was pointing on my left side after you put your head down. I did. I was pointing right. You said gallbladder. Then I went to the left, but you weren't looking. Kidney pain radiates to the flank, right? Like they'll have flank pain. They may have lower back pain. Alright, so what are we gonna do?
Yes, I've seen it.
Be a size safe, right? We wanna take our general impression, we're gonna look at the patient. I always wanna know, like, do I say sick, not sick, right? I walk in the door, I do my doorway assessment, I look at my patient, and I'm like, if I go, oh shit, in my head, no, then they're sick, and I know I gotta move a little faster than if I'm like, alright, they look okay, and they look weak, and they're looking at me when I walk in. ABCs always, no matter what. I don't care if you stub your toe, I'm gonna ask you to open your mouth, I'm gonna look inside, I'm gonna check your airway, I'm gonna listen to your lung sounds, I'm gonna do my ABCs, okay? I wanna make sure I'm not missing anything. And we're gonna focus based on complaint, presentation, etc. Beyond that, we'll do OPQRST. So today is medical, yesterday was trauma. OPQRST really doesn't apply to trauma. Sample does, but not OPQRST. Prior history of similar event. Has this ever happened before? Do you have any surgeries? Like, you know, did you have your gallbladder removed? Do you still have your ovaries? God bless you. What is wrong with everybody tonight?
I think we're all getting sick. I saw you, I think you need to go home.
Yeah, no,
I think it's the allergies. I can't even come close to touching my eyes. It hurts so bad.
I saw a gallbladder get removed today, actually.
Yes. Very cool, right?
Yeah.
Laparoscopic, they pulled it right on out, right?
I did one pop in.
If you're asking about a prior history, you know, is it exactly the same on a scale of 1 to 10? How do you rate this compared to that? You know, go through all the different types of questions. OPQRST is a starting point. It is not the be-all, end-all, so it should give you some information to start asking more questions. We really do have to play detective, okay? Nausea, vomiting, recent weight loss, recent weight gain, urinary frequency. Does it hurt when they go? You know, again, change in bowel habits. What does it look like? What does it smell like? When did they eat last? What was it? If it was McDonald's, face my partner. Do they have chest pain with it? Right? And then anything unusual to go with any of these questions, right? Some of these are not always fun to ask, but you know, we just need to know because it might help with our diagnosis. What do they look like? Are they really uncomfortable? They can't sit still, right? They're agitated. They can't walk. They can't sit. Or they're sitting so still in a ball that if you touch them, they're so in much pain and they're, you know, immediately upset, right? Or does it like, I feel better when I'm walking, I'll walk it off, right? Where is their level of consciousness? Are they altered because they have too much waste byproduct in their system and it's causing altered mental status, right? Because nitrogenous waste is not good for our brain. What's their oxygen level? Are they running a fever? What's their blood pressure and pulse rate? We're looking to make sure they're not hypotense. They could be in shock. They could also be septic. And then figure out what's baseline. You know, what is normal for these people, because if their baseline is altered, then that's going to make it a little more difficult. Typically, kidney stones feel better when they're trying to walk it off, because it kind of moves the stone around a little bit. It's not stuck. So that usually gives you something. If they're feverish, hunched over, they might have pyelonephritis, which is a kidney infection. And then peritonitis is usually if they're drawn up at their knees. Their whole abdomen hurts. What's their normal apparent state of health? What's their skin look like? Do they have any rashes, edema, pitting edema?
Time to wake up.
You alright?
Scare the crap out
I
of
know, I
me.
was like, where are we going? Class dismissed. We're going to inspect the abdomen. We're going to look for scars, tries, just like we did last week during abdominal assessment. We're going to palpate. We're going to look for ecchymosis. We're going to list the bowel sounds. Again, anything abdominal related, we always want to thank female childbearing years, possible ectopic pregnancy to prove otherwise, just because that will kill somebody. All right, masses. Do they have masses? Are they palpating masses? And if they are, stop touching them because they're going to explode. And then get your vital signs. You know, I know we don't listen to bowel sounds a lot. Typically, we're listening for either too much or not enough, right? So if they're not really making a lot of sounds, like one sound every minute, then it's probably not enough. And if they're making a lot of sounds, like everybody knows what their stomach sounds like when it's gurgling. That's hyperactive bowel sounds, because something's happening. So less than 5 in a minute is considered hypoactive. more than 35 in a minute is hyperactive. All right, so 4 quadrants versus 9. Everybody knows the 4 major quadrants. So if you want to be a little bit more specific when you do your exam, you can break it into 9 quadrants. Okay, so you have your right and left hypochondrials on either side of the epigastric, which would be kind of for your stomach. And then lumbar, so right and left lumbar with the umbilicus, which is your belly button. And then iliac, right and left with your hypogastric, so lower than your stomach. All right, so if you really, like if you had somebody who had a 3-inch laceration to the right lumbar region of the abdomen, that's a little bit more specific than somewhere in the lower right quadrant, but everybody knows this, so this is fine. That's just a little bit extra. All right, so we're gonna do our ABCs. We're gonna make sure that there is nothing life-threatening that we need to treat in airway, breathing, or circulation. And if we find something, we're gonna stop and treat it immediately. I know sometimes we're just starting scenarios, we're just starting to get moving, you're just learning, so that's fine. But as you progress, that sense of urgency needs to start to come a little quicker, right? If you hear something bad about an airway, breathing, or circulation, immediately you need to start thinking about what am I gonna do to fix that? Whether it's BLS or ALS, but we need to be a little bit quicker on our feet with some of that stuff. IV access. Again, depending on the patient, if they have a fistula, we're not going to put an IV in that arm. Fluids, too much, too little, yes, no, maybe so. Right, depends on your patient. If they're fluid overloaded, obviously we don't want to give fluids. If they're hypovolemic though, even if they have kidney problems, we still need to give them fluids because we know the kidneys need fluids to function, right? Analgesics, what's the problem with those? Sometimes they can mask the symptoms. Some analgesics, it's not a big deal if you give a low amount, but some things are toxic to the kidneys. You just have to watch where, again, that they're excreting. Nothing by mouth because they might need to go to surgery. Not that we usually feed and drink our patients anyway. Whatever's comfortable, right? If they prefer to be knees drawn up because that's most comfortable, as long as you can secure them safely on the stretcher, that's fine. I mean, you're not going to strap them down flat.
I had a genuine question from a PA student today
That's fine, but why all of a sudden the mask?
y'all motherfuckers are coughing too much. I ain't catching nothing.
Oh, I was like, all of a sudden
I ain't doing this. I ain't doing this.
Oh, no, that's fine.
NPO, obviously if they're vomiting and all that stuff, Zofran count as by mouth if we give it can I give Zofran orally if they're NPO?
Yes, because NPO means fluids and food in the stomach, because if they have to operate, they don't want them to vomit. But
I thought so. The PA student made me question my entire life because she was very, very my dog knows more medicine than she does.
okay.
So she's like 4th year,
I've
yeah.
never taken Zofran as a nothing by mouth, you can give it when it's, I always consider NPO food and drink. Don't give them anything to eat, anything to drink, because if they go to surgery, it's going to be a problem.
I'm
If
just
you're
double
trying to
checking.
prevent them from vomiting, I would think Zofran would be okay, but you could always give it.
I'm just double checking because, like I said, the PA student asked me, and I was like, should be fine. And then
I don't see anything wrong with it. I can double check with Dr. Brooke later, but I don't see it. Okay. All right, so the renal and urological emergencies we're going to talk about, obviously acute renal failure or acute kidney injury, AKI or ARF, and then CKI, chronic kidney injury or chronic renal failure, and then kidney stones or calculi, UTIs. What happened? You guys all right?
We're fine.
You good?
So,
Should I go get some
no,
candy?
there was a question about if there's a venous fistula up in the brachial region, right?
Even if it's all the way up here,
Can't start an IV down here.
Leave that arm alone.
Yeah.
Because you're going to put any pressure on that to blow it. Plus, definitely no blood pressure cuff over that, Yeah.
knew that, but I didn't know that I could hurt.
Diabetes, high blood pressure. 2 main things that cause kidney problems.
Didn't mark that.
The 2 main causes of renal disease. Diabetes and high blood pressure. Okay.
I overthink
What, hypo?
Blood pressure was my favorite
Trauma.
option.
It's not really a risk factor. Trauma is like an actual emergency. All right, so hematuria, blood in the urine. You can have gross hematuria, which is lots of blood that you can see visually. And then microscopic hematuria, which means you have to go to a lab and they have to get it in the urine and they spin it out. They look at it under a microscope and decide if you have blood in your urine. Again, we're not going to do that in the field, but I mean, if they have gross hematuria and they're peeing blood into the toilet, that's definitely something they might be able to show us when we get to their house, and definitely something they can communicate to us, when we get there.
Or in the Foley bag, you will see.
Or in the Foley bag, right, absolutely, that you'll see like bright red, blood. Or dark brown tea-colored urine, which is also not good. Right. You can smell that from a mile away. Okay. So AKI, which is acute kidney insufficiency, is something that develops quickly. It's acute and it's usually fixable, and if you fix it pretty quickly, it will repair itself. Okay, versus chronic is there's some damage to the kidney and it's going to be happening for a while. Okay, so acute kidney injury happens when something happens and they can't do their job, and then some stuff backs up, right? And we know all the functions of the kidney, so we know if it's not functioning properly, all that stuff is going to be affected. So electrolytes, water, blood pressure, acid base. So prerenal is the most common type, most common in hospitalized patients. There's some reason for ischemia. Elderly patients, atherosclerotic disease, again, like narrowing of the vasculature going to the kidney, diabetes, any kind of hemodynamic compromise, and then the nephrotoxic drugs, right, ACE inhibitors, and SEDS can be bad over time if you ever take too many of them for too long. Antibiotics can also cause problems. So you have pre-renal causes of acute kidney injury, intrinsic or the kidney itself, and post-renal, which is really more urinary. And intrinsic, we're looking at either the glomerulus has got a problem, the interstitial area, the tubules, or the vasculature. But anything has to do with the kidney. I don't think we're going to get deep dive too far down those pathways, but just so you can see that there's some different sections. So pre-renal, anything before the kidney, pre-renal. So hemorrhage, MI, CHF, sepsis, shock, anything that's affecting the ability of blood supply and hypoperfusion to the kidney itself. So it's considered a pre-renal cause. So if you figure out what's causing it and you fix it, you're good. Intrarenal, again, having to do with the kidneys themselves, problems with the blood vessels, inflammation or infection of the tissue, so pyelonephritis. Okay, glomerulitis, inflammation of the glomerular capsules. And then post-renal is obstruction that blocks urine flow. So if you can't pee, God bless you. You can't have an outlet, then it backs back up into the kidney. So, so anything that's going on with the ureters, the bladder, or the urethra is post-renal. Obviously, if it's happening to just one kidney, the other kidney will pick up for as long as it can to cope, just like anything else in our body. But it can only do that for so long. That's why people have to go to the hospital and get treated. So how will they present? Nausea, vomiting. They don't want to eat. They're going to be weak. Maybe confused. Itching, pruritus, right? Because they have all these toxins floating around in their body. They may have edema, volume overload, CHF. High blood pressure. They may have tea-colored urine because they have an infection, or they're super dehydrated and they're just peeing out this really disgusting concentrated urine. Okay. When you go to the bathroom every day, your urine should be light yellow to clear. Right? If it's much darker than that, you're not drinking enough fluid. And if it's really dark brown, your kidneys could fail, so you don't want to do that either. Okay. So signs and symptoms for pre-renal: low blood pressure, tachycardia, dizzy thirst. Intrarenal, they might have the flank pain, because again, we're talking infection typically when we're talking about the kidney itself. Oliguria, so lower urine production, high blood pressure, headache, confusion, possibly seizures depending on how bad this is and how much nitrogenous waste is building up in the body. Post-renal, pain in the lower flanks, abdomen, groin, again, because you're talking about the urinary bladder, the ureters, and the urethra, so think about where those are located. Again, decreased urination, distended bladder, because if it's backing up, it's backing back up into the bladder. Maybe blood in the urine, and some edema. If you're not excreting all the electrolytes properly and you have potassium built up in the system, what are you going to see on the EKG monitor? Peaked T waves, right, for hyperkalemia. So we're going to ask a bunch of questions. Have they had a fever, any recent infections, right? Do they have a prostate, and if so, have they been told it's enlarged? Do they have a history, any symptoms? Do they have previous renal disease, and what medications are they taking? Any change in their urine, all of that stuff, we want to know. Azotemia is the nitrogenous waste built up, and if you get uremic frost, when it comes out in your sweat and deposits on your skin, you get this like very fine, salty, smells like urine. Don't taste it. It's disgusting. Oh, Mackenzie. You're gonna do a physical exam. Again, they could be altered nitrogenous waste. High blood pressure or low blood pressure, tachycardia, hypoxia. Pale, full, clammy. Right, you're thinking about shock, sepsis, like any of those things, you're gonna start seeing the same thing. Electrolyte imbalance, you're gonna see EKG changes. You're gonna have dysrhythmias. You're gonna have things that you don't like, and if we don't fix it, they're going to go into arrest, right? Because cardiac function relies heavily on the sodium, potassium, calcium pumps. We talked about all that already. Hyperkalemia, slow, irregular pulse. They're gonna be weak. They may have some tingling in their hands and feet. Again, that EKG finding is going to be the wider QRS with a tall peaked T wave. So you see the part of T waves. So this is not good. It's a pretty significant change. If you're not careful, this can turn into VTAC and then VFib. Right. So the higher and higher the potassium levels get, the wider and wider the QRS gets. You turn into a sine wave, and it turns into VTAC, and then you can call it a day. So this is really bad.
Bad squiggles.
Wow, bad squiggles. And really bad squiggles.
Bad
So now we're
squiggles.
starting to we're pulling the EKG out into like that nice sine wave. And then, oops, I don't know what happened there. Death. They all died. So yeah, sine wave, and then it looks more like VTAC, and going into VTAC. So definitely potassium can kill you. So ABCs, make sure they're oxygenated, get an IV, but again, check their fluid status, right? Where's their blood pressure? Are they perfusing their kidneys? What's their MAP? Is it at least 65? We don't want to fluid overload people. We don't want to give fluids to people who don't need it, but if people need it, we want to make sure they get it, okay? Obviously, any of the patients who either have a history of kidney problems or you think they're having a kidney emergency, they need to be monitored, hence EKG rhythms, I just showed you. Try not to give meds unless they absolutely need them, and before you give them, double check and make sure they're not nephrotoxic. And if you're not sure, call med control. They're your friends. Treat shock, treat volume depletion, get them to the hospital. Okay, hyperkalemia, too much potassium, we treat that with calcium. Okay, 500 milligrams per gram of calcium. Then they need insulin in the hospital, but they'll also give them glucose at the same time and measure their levels. We can give albuterol because that will also push potassium back because it's an adrenergic agonist. Again, we're not giving diuretics anymore pre-hospitally, but we used to carry Lasix. But they can also do hemodialysis in the hospital to try to rebalance everybody else. But our goal is calcium if they have hyperacute T waves and we think they have hyperkalemia. Monitor their EKG. Make sure that their systolic blood pressure is around 90 or their MAPS is 65, and that they're kind of where we need them to be until we can get them to the hospital and they can do other stuff. All right, so CKI or CKD risk factors, again, diabetes, hypertension. Now we've moved into not an acute situation, but now they have some permanent loss of function of about 30% of the nephrons in their kidneys. Okay? All of these things are risk factors, so cardiac disease, autoimmune disease, infections, over and over and over again can cause, permanent damage to the kidney. Certain races, African American, Native American, Asian American, tend to have a higher risk for kidney disease, and then cancer, family history, all this stuff. Okay, these are all risk factors. So again, that's your autoimmunes, glomerulonephritis infection. Structural function abnormality for 3+ months is considered CKD. Complications from chronic renal failure. Okay. Hypertension, diminished urine output, fatigue, itching. Right? So a lot of the same things, but on a long-term basis, and they can't be fixed anymore because the kidney is permanently damaged. Okay. And again, cognitive impairment, and we're worried about seizures because of the nitrogenous waste. The electrolyte imbalances will cause third spacing of fluid, so you end up with all those very large pedal edema, swelling, and then of course acid-base balance issues, so acidosis. Routine ALS care, right? Airway, oxygen, IV, EKG, transport. If they're hypertensive, and we might have to. Pressure for hypertension. It must be for hypertension. No, I just said it's for hypotension. Consider a vasopressor. I use the same shorthand. Long-term treatment, obviously dialysis is important, and that will help try to maintain their electrolyte levels and their acid-base levels. But permanent treatment is transplant. Like that would be the only way to get them back to somewhat of a normal situation is if you actually had a transplant performed. But then you have to worry about rejection, taking autosuppressants for the rest of your life. But if you're ever asked what the definitive treatment for chronic or end-stage renal disease is, it's transplant. All right, so end-stage renal disease, kidneys are, pretty much shot. All the same things that we just talked about, but just to a much higher level because the kidneys just really are not doing, and a lot of edema because the kidneys just cannot maintain water. I'm sorry, go ahead.
Can they survive on dialysis without the transplant if they can't get?
Yeah, but they'll be on dialysis for the rest of their life. Because once you're on dialysis for something like this, it's either that for the rest of your life or a transplant. So dialysis, there's two different kinds. There's peritoneal and chemo. So where they either do anastomosis or a shunt, and they do a blood thing a couple days a week, or every night the person can go home and dialyze for their 8 hours while they're sleeping through their abdominal peritoneal membrane. But the whole point is to remove those chemicals and those nitrogenous wastes and the excess electrolytes that are not where they belong, and kind of try to restore them to some level of hemostasis. Okay, all that excess fluid comes out. Let's see if this will work.
exit the body through the urethra in the form of urine. If you have kidney disease, your kidneys gradually lose function, leading to an accumulation of harmful waste and excess fluid in your body, increased blood pressure, and bone or blood problems. Dialysis can also be done to treat acute kidney failure, which occurs when your kidneys stop working suddenly, or to remove drugs or poisons from your body. In one type of dialysis, called hemodialysis, your doctor will use a machine called a dialyzer to clean your blood outside your body. Some weeks or months before you begin hemodialysis, your doctor will prepare a vascular access site on your body. Your doctor will create either an arteriovenous graft or an arteriovenous fistula to access your bloodstream. To begin, he or she will numb the area with local anesthesia. To construct an arteriovenous graft, your surgeon will make a small incision in your forearm and insert a soft plastic tube called a graft to connect an artery to a vein. To create an arteriovenous fistula, your surgeon will make a small incision in your skin and connect an artery with a vein to make a larger vessel called a fistula. Once your vascular access site has healed, your doctor can start hemodialysis. To begin, your dialysis nurse will insert 2 needles into your AV fistula or graft. Once the circuit is set up, your blood will flow slowly out of your body and through the dialyzer. Inside the dialyzer, your blood will encounter filtering fibers and an absorbent cleaning solution called dialysate. The fibers will remove waste and excess fluids and electrolytes from your blood. Your cleaned blood will emerge from the dialyzer and continue through the tubing, back into your body through the second needle at your access site. When your hemodialysis session is complete, the needles and tubing are removed, and you can go home. In another type of dialysis, your doctor will use the membranes lining your abdomen, called the peritoneum, to clean your blood without removing it from your body. Before you begin peritoneal dialysis, you will have an operation to implant a soft tube called a catheter. Your surgeon will insert the catheter near your belly button, creating a port through which the dialysate will enter and leave your abdomen. Each peritoneal dialysis session is called an exchange. First, you will use your catheter to fill your abdomen with dialysate for a period of time determined by your doctor. Through the peritoneal membrane, waste products and extra fluid are continuously drawn out of your blood into the dialysate. Along with the waste materials it absorbed, the dialysate will drain out of your abdomen into a disposable collection bag during your exchange. This is the blue salt recipe that took me from 198 to 147 Egypt.
Wait, can we watch them?
Maybe that's all we need, baking soda.
Baking soda, pink salt, we'll all be fine.
Just rum up a little bit.
It's good to go, we're fine. Oh, alright, so you saw how they combine an artery and a vein. So when that heals, you should be able to feel what's called a thrill or auscultate a bruit. So that you should have some turbulent blood flow because it is an artery which is under pressure. So when it doesn't, if you can't feel like a pulsation there or you can't hear blood flow, that's a problem. Then there's a problem with that fistula. So if you ever see a fistula and you want to just make sure it's okay, you can always just try to see lightly if you can feel the turbulent blood flow, or you can listen with your stethoscope to see if you can hear what's called brewing. So it's just a picture, but we just talked about that. So complications of dialysis. How many people go to the dialysis center and take patients? Right. We know that they can bleed from the catheter site. If they take too much fluid off too fast, they can get disequilibrium syndrome and get dizzy. And they can actually fill up their ventricles in their brain with excess fluid and get fluid overloaded. They can have high blood pressure crisis. They can have pulmonary edema. Their electrolytes can be all over the place, especially their potassium. So obviously we got to be careful with these patients because they're already pretty sick, and that's why they're going to dialysis. So they can have all kinds of problems.
I have a question.
Yeah.
How would they get air embolism?
From the process with the machine.
Okay.
Just like any time that we do a medication, we have to be careful not to inject air.
Air.
Same
Okay.
thing. We mentioned this a little earlier, but don't take the blood pressure on the extremity with the device because you could destroy the device. Don't put any kind of direct pressure on it unless it's bleeding profusely and you have to stop the bleed because since it is tied to an artery, it will bleed pretty bad. Don't use the device to access for anything, like we're not using it, like basically pretend that arm doesn't exist. If it becomes disconnected, try to reconnect it. If not, apply pressure so it won't bleed. ABCs, intubate, ventilate, CPR if needed, transport. We just have to treat whatever the problem is in the moment and do whatever we can and move fast because these patients, we can lose them pretty quickly if we're not careful. Again, since there is an artery involved, it will spurt, okay? It will come right out and bleed quite a bit. So you need a lot of pressure, direct pressure, holding down. And one of the renal doctors told me to use a cap from a water bottle, put it over and tape it down as tight as you can because that will put pressure over the hole. So again, we want to give fluids, we just want to be careful with our fluid administration. So 50 milliliters increments, like really low volume, just a little bit at a time, get their pressure up. Again, reconnect the shunt if it becomes disconnected, checks for signs of shock, potassium imbalance, treat bradycardia. If it's hypo, obviously give calcium and bicarb if they're hyper. Supportive treatment, we really can't do much with disequilibrium syndrome because that's the osmolality problem in the brain. Air embolism, we can't really do much about that. We just gotta give them time for the air to get out as long as it doesn't cause a heart attack or a PE. Problems with the machine, CHF. I mean, any of these things you're gonna treat the actual issue, right? If they have congestive heart failure, we're gonna treat congestive heart failure. If they have having an MRI, we're going to do all the things that they're competent in. All right. Big deal, you pass the kidney stone. Think about what I do for a living. All right, you got 10 minutes.